All right, welcome everyone. What we're going to go over in this shorter video, we're going to be straightforward to the point and try to keep it simple. We're going to go over the do's and the don'ts of infant pediatric mechanical ventilation and transport utilizing the Hamilton T1. This is specific to our program currently. Anyone else that may be watching this video, please follow your own policies, procedures, and protocols when ventilating. So we utilize the Hamilton T1, and we're going to cover some of the differences between adult ventilation and infant and pediatric ventilation. Unfortunately, for the most part, they're very similar. We're using, the same modes, the same settings typically. We're maintaining the same safe pressures, and we're staying within a certain tidal volume range for each age range. So we're going to cover the importance of eliminating dead space first of all. So we're currently using pediatric vent tubing with patients that are 15 kilos or less, and that's what we're recommending. Now, if you feel like you want to use this setup with larger than a 15 kilo patient, you're more than welcome to. This is just kind of a lower weight for where we prefer that you would switch to using the PEDS neonate vent tubing versus the adult tubing. And you'll understand why in a minute or so. So with this, we're utilizing our pediatric end tidal CO2 as well as the adult pediatric flow sensor. And the reason we're using the adult pediatric flow sensor is because with our current setup and our ventilators, we do not have the neonatal software installed on the T1s in the aircraft or in the mobiles. We do have our NICU ventilators. They have 2 ventilators that we're able to utilize that do have that software. So that's why the adult pediatric flow sensor. We're going to consider the HME if dead space ventilation is not a concern, and you'll also see why here shortly. Any filters that you wish to place, the HEPA filters or anything else, place those on the ventilator at the expiratory valve. So the biggest difference between PEDS and adult is that we're going to start with 8 milliliter per kilo tidal volumes with kids. And we'll show you exactly why here. So this is our adult setup. So from the beginning of the end tidal CO2 connector up through that swivel adapter, and notice this is not the swivel adapter with the corrugated tubing or the slinky adapter. This is just the standard swivel to the flow sensor and up to the Y. We have 38 milliliters of dead space. So from the very beginning up to the Y, where it goes down through the corrugated tubing and makes its way to the expiratory valve. So if we set the height of the patient and the ventilator defaults to the 6 milliliters per kilo, that's going to be a 30 ml tidal volume for a 5 kilo patient. Well, we have 38 mLs of dead space utilizing this setup. That's 126.6% mechanical dead space. So all we're doing is we're constantly rebreathing the exhaled CO2. So what if we have a 10 kilo patient? Well, 10 kilo patient at 6 milliliters per kilo, that's 60 mLs. We still have 63.3% mechanical dead space. That is dangerously high. So that shows you exactly why we chose to switch to our current setup that we're using now for children, which is this here. So we have the PEDS neonate end tidal CO2 adapter up to the blue part, the flow sensor, that is the adult pediatric, and then we have the PEDS neo tubing that connects to the ventilator. So all that total from the end tidal CO2 up to that Y, or the exhalation tubing, we have approximately 13 milliliters of dead space. So let's look at that same 5 kilo patient, and we're ventilating what it defaults to. If we leave the vent right where it defaults to at that 6 milliliters per kilo tidal volume, we're at 43.3% dead space. Well, let's look. What was the adult? The adult was 126.6%. Okay, so significant difference. Now, what happens if we increase the rate to attempt to blow more CO2 off? Does increasing your rate decrease the amount of dead space? Well, the answer is no. All we're doing is increasing the rate, and it's still the same percentage of dead space with a higher rate. So the reason we choose 8 milliliters per kilo as a starting point for infants and small children is because of the dead space ventilation. So now if we have a 5 kilo patient at 8 milliliters per kilo, that's a 40 ml tidal volume instead of 30. So that decreases the dead space ventilation to 32.5% from 43. So almost 11% difference just by simply optimizing that tidal volume. Well, what about rate, you ask? Well, with rate, what we would suggest is that you utilize your Breslau tapes and you utilize your resources to find an appropriate respiratory rate for the age group that you're ventilating and start at the lower rate. We want to optimize tidal volume, and we want to use the slower rate if at all possible. And I will explain that once I go over the vent portion at the end of this. So what happens if we add even one of these little tiny HMEs that we have? It doesn't look very significant. However, those hold approximately 5 milliliters of tidal volume. So now we have 18 milliliters of dead space even on our PEDS setup. So our same 5 kilo patient at 6 milliliters per kilo, that's 30 mLs tidal volume, we have 60% dead space adding that HME versus just 43.3 without it. So pretty significant increase in the percent of dead space. And then again, the 5 kilo at 8 milliliters per kilo, optimizing that tidal volume, that's up to the 40 ml tidal volume, is down to 45% dead space versus the 32.5. So you can see the increase just by adding one simple little piece of equipment in here, how significant that is. So what do we have? How can we tell with the equipment that we have whether we are high with the dead space ventilation or we have too much dead space ventilation? Well, start with CO2. So we're up at the top, we're at the dotted line. We're showing an exhaled CO2 on this of 40. So as the graph starts to move down, that is our inspiration or inhalation, and you can see it makes it all the way to baseline. Then during expiration, it goes back up and it measures the exhaled CO2. This is a normal end tidal CO2 waveform right here. So we can look and see that this is normal. What happens when we are rebreathing CO2? Well, you can see how during our inhalation, it goes down towards that baseline and it doesn't quite make it there. So that means that we're rebreathing CO2. So exhalation, going back up, and it never makes it back down. So that could be your first clue just by simply looking at our the ProPak MD once you attach your end tidal CO2. The other way that we can tell, once you have that end tidal CO2 attached and you look at the right side of the ProPak, where the end tidal CO2 is, you'll see a small number just below that. That's it says FiCO2. That is the fraction of inspired CO2. So on our ProPaks, the default alarm for all the patients, for adult, pediatric, and neonate, it will alarm if it is 8 millimeters of mercury or greater. So keep that in mind. You can look, the goal is to have that FiCO2 0 or as close to 0 as possible. At this point, we'll move on to the ventilator, and we're going to go over the modes that's preferred, and we'll go over settings, and we'll explain why we're doing what we're doing. All right, moving on to the Hamilton T1 for your infant pediatric ventilation. This is our startup screen here. We notice that we're defaulting to the volume controlled adaptive mode. The preferred mode for ventilation is going to be a pressure mode for children. So the difference between the two modes, when you use this volume adaptive mode, the ventilator is going to attempt to adjust itself internally based on its protocol. So when you use a volume mode and you're showing your volume here, you want to set the volume, you want to make sure that it's delivering the tidal volume close to where you have it set, but you want to monitor the pressures. When we use a pressure mode, we want to monitor the volume. So it's exactly the opposite for each one. So let's go down to our 5 kilo patient that we were talking about earlier. So we can show you guys the numbers. So we're at 18 inches, 5 kilos. Remember to get your Breslau tapes out, get the tape measures out, and make sure you have a really accurate, ideal body weight for your patient. So we'll go with our 5 kilo male, 18 inches. We're going to go to mode. And we're going to switch to the PSIMV for pressure support. So we're at pressure support, and you'll see this default settings screen here. So we want to make a couple changes right off the bat for the PSIMV plus. So you'll notice it defaults to an I to E ratio of 1:4 and a rate of 35. So for this age group, we want to go to that the lower limit of what's normal and start. Now we'll start somewhere around 28 or even 30. Okay. And then this IE ratio, think of the IE ratio for kids kind of like an adult obstructive. We need to allow a little more expiratory time because they have such narrowed and restrictive airways. They trap the air more than an adult airway does. So let's start with going to our I time here, and let's make that IE ratio a 1:3. The adult is typically 1:2 for an IE ratio, so we're a 1:3, allowing a little bit more expiratory time. Oxygen, I'm not going to drain our aircraft, so we're going to go to 21% with this. We're going to adjust that FiO2 down as low as we can and maintain 93% or better oxygen saturation. So this looks good for our 5 kilo patient to start with. Click confirm and start ventilation and see where we're at. Typically with inspiratory pressure of 15 and 5, most kids you can ventilate all day and get good expiratory minute volumes and good tidal volumes, but it really is patient dependent, so we may need to make some adjustments with this. Our expiratory minute volume for a normal patient, not acidotic, not alkalotic, just normal ventilation, we want approximately 200 mLs per kilo expiratory minute volume. So we want to be around 1 liter for a 5 kilo patient. So we're getting tidal volumes a little lower than our 8 per kilo that we want. So what we want to do is we want to come over to the pressure and go a couple at a time. Now remember, your inspiratory pressure plus your PEEP is going to equal your peak. The peak on the Hamilton is very closely related to the P-plat. And we don't want the P-plat above 30 because our ultimate goal is not to cause harm. So we need to monitor tidal volumes, stay within the tidal volumes of 8 and sometimes even up to 10 per kilo for good healthy lungs. If we need to increase our expiratory minute volume, and blow more CO2 off. So right now we're about 35, 36, so we're getting a little bit closer. Let's try this. So we're real close to our 8 per kilo now because we've gone up on our pressure. So 19 plus 5, we expect to see 24 for our peak pressure. Remember, we don't want to go over 30. And a normal infant, we could ventilate them just like this right here. Expiratory minute volume is slightly high. If our end tidal CO2 is dropping too far and we're blowing too much CO2 off, we could potentially go down just a little bit with the pressure. Or to decrease our expiratory minute volume here, we can go to our controls and we can decrease our rate just a little bit. And you can leave it right on this screen here and you can watch the changes there. So we're at 28. I want to decrease the expiratory minute volume slightly. And you can see that that's going down. And we're still maintaining around 8 mLs per kilo for our total tidal volume. That's with a standard healthy lung, normal patient. So if we go into monitoring over here, the lung that I'm using is not good for the inspiratory pressure and C-stat, so we will ignore those. With our pressure modes, a lot of times you can get a good plateau pressure here, but if it's showing the 3 dashes, what Hamilton suggests, and it's actually in Hamilton's manual, if you look just below your plateau pressure, and this works with adults and pediatrics, you'll see that 16, there's a little delta sign, that's your driving pressure. On the Hamilton, if you take your driving pressure and you add your PEEP, it gives you your plateau pressure. So driving pressure plus PEEP equals plateau. So for any of those times you want to document your plateau pressure and it's not displaying it for you, that's how you get that with the Hamilton. So let's say we have a child that is, let's say, a DKA, metabolically acidotic, their pH is 7 or lower than 7. We're doing everything we can not to intubate the child, and we notice that, we put them on the nasal cannula end tidal CO2, and their end tidal CO2 is actually low, 10, 12. We want to be very careful with these kids because if we have to intubate them, we want to maintain that same minute volume and maintain that end tidal CO2 exactly where they were maintaining it prior to the intubation until we can get blood work and we can verify where the vent settings need to be. So for example, our expiratory minute volume is around 200 per kilo. For our expiratory minute volume for a normal patient, if we need to increase the expiratory minute volume to blow more CO2 off to maintain them at that lower end tidal CO2 for those severe metabolically acidotic patients. What can we do to increase that expiratory minute volume? Well, we could get a little more tidal volume out of it. Right now we're at 8. We could go as high as 9 or sometimes even 10 if it's easily tolerating, but we can go into our rate here and you'll be able to see as I increase this rate. Let's go up to 32. Right now we're at 1.02, 1.01 expiratory minute volume. Let's bring that rate up and see what it does, and we can leave it right on this screen and we should be able to see a difference. So right now we're already increasing. Now it's important, if you're going to increase the rate, we try to maintain somewhere close to a 1 to 3 if we can. We may need to adjust that I time a little bit, but we need to go back and we need to look at our flow waveform here. And what we're looking for is our inhalation is above the line, exhalation is below the line, and it's returning to baseline after that exhalation. That means we're not trapping any air, just like the obstructive one that we went through. And you can see that we have time in between each one of these cycles where nothing is happening. There's no air going in, no air coming out. So we can actually increase the rate or increase the I time to fill those spots in. So we want to blow more CO2 off. We've got time, we're not trapping air. We can go back into our controls and we can increase the rate. Let's try 36. Let's look at our expiratory minute volume and see what it does. And we should see an immediate feedback in pressure mode. So we're increasing. So we can go, we could go up to 300 per kilo for an expiratory minute volume. So that'd be 1.5 liters per minute. So let's increase that some more. Once we increase that, let's go back and make sure we're not stacking any breaths and we're not trapping any air. We still have room to work. So if we like the tidal volume, our pressures are good, we can increase that rate even further. So we can go back into controls. And look at our expiratory minute volume increasing. So we're at 1.6. This is only if we need to blow off excess CO2 for those severe metabolic acidosis patients. So typically 200 per kilo, 5 kilos, that would be a 1 liter expiratory minute volume. Like I said, increase or decrease your FiO2 as necessary to maintain a good oxygen saturation. We want to be able to lower that if we can. And that's the basics for ventilating infants, pediatrics. Pressure mode around a 1 to 3 IE ratio. And that's pretty much what we're going to do to adjust to fill the time in. Like I said, try to keep your IE ratio 1 to 3. Adjust your rate as necessary. We're in pressure mode. When you're in pressure mode here, monitor your tidal volume. If you are in your volume mode, you want to monitor pressure. So it's exactly the opposite. Hope this helps you guys.